Hello, welcome to season 5 of the Baby Manual podcast. This season, I'm interviewing pediatric subspecialists so that they can tell you all about the special things that they do in their fields, reasons that you might get referred to a subspecialist, and also things that you can try at home before your specialist visit. Today, I have the pleasure of talking with Dr. David Tegay, who's a DO, and he's one of the most brilliant people I've ever met. He talks all about genetic testing and why different families choose to get genetic testing and the sorts of things they can find, and also how the testing is done. So I hope you enjoy it. Hello, welcome to this week's episode of the Baby Manual podcast. Today, I have the pleasure of talking with Dr. David Tegay, who's a DO and a geneticist. So Dr. Tegay, tell me a little bit about yourself and how you got into genetics and where you work, that kind of thing.
Absolutely. Thanks so much, Carol.
Yeah.
So I first found out about genetics while I was actually in residency. It still isn't the most common path for doctors to take. And in fact, not one that's talked about probably nearly as much as it should be during medical school. So when I got to residency, there was a really interesting case, a patient who had a not so rare genetic condition, but had some really unusual findings that didn't go along with that diagnosis. And so everyone was really perplexed as to what was going on. Why would they would have these other things that you normally wouldn't see with this already, unusual genetic syndrome. So they called in a clinical geneticist, which I didn't know existed at the time. It was a relatively small community hospital. Geneticists are much more common at large tertiary care medical centers. So she came over from Mount Sinai to do a consult on this patient, and immediately was able to discern exactly what genetic syndromes were present just from physical exam. And then we were able to confirm that, on genetic testing. And so for me, that was just fascinating. It was like a little bit like playing house MD with genetics. So I was hooked. I was in an internal medicine residency at the time, which is not the most common pathway into genetics. It's most often from pediatrics because most genetic conditions are often identified during the pediatric period. But they said, look, we would really love to have you do a fellowship in genetics. And the fellowship is age agnostic. It's a clinical geneticist can see patients of all ages from birth and even prenatally all the way through adulthood. So I completed my fellowship over at Mount Sinai, and then the rest is history.
That's really cool. And I think we all know that, genes live on chromosomes and there's different types of genetic testing. Can you talk a little bit about what does a genetic test look like to a patient? I assume is it a blood test? Is it a cheek swab? Where do you get samples from and what kind of things does that tell us?
Oftentimes when patients hear the word genetic testing, it creates some anxiety and some uncertainty about what is going to be involved. But in truth, most genetic tests are no different than any other routine laboratory testing that you're going to do in terms of how we obtain the sample. Historically, we would obtain a blood sample to perform genetic testing. But now it's much more commonplace even to obtain a genetic sample on a cheek swab or a saliva sample, so non-invasively. The thing about genetic testing that makes it different from, let's say, a routine test like, checking your blood counts to see if you have anemia, which is either like a yes or a no. You either have anemia or you don't. Or a pregnancy test, you're either pregnant or you're not, right? But with a genetic test, what they do is they read, in many cases, the chemical letters of the DNA sequence, or they look for variations in the formation or the copy number, as we call it, of the chromosomes. And when they find a change, they have to interpret whether it's significant or not. And many times they can do that and give you, yes, we found an answer for whatever we were looking for on the test. Or sometimes, no, we didn't find any problems, which doesn't give us an answer, but at least tells us it's not a problem with whatever we were testing for. But many times when they find a change on a genetic test, the lab is unable to confidently tell us whether that change would result in issues or not. And we call that an uncertain variance. So there's a lot of counseling that has to go into genetic testing because we have to explain to people that when the result comes back, it could be a yes or a no, but sometimes it's a little bit in between, and there may be other things we need to do to resolve that uncertainty if we can. And then, of course, because we're looking for genetic changes, there can be implications for other family members in some cases when they're heritable, which they not always are, but sometimes they could.
That's really neat. So the gene might be there, but it might not be doing something, or it might be doing something in a different way than you'd expect. That's really cool. So how does that come into play with like prenatal genetic testing? Because I know, back in the day, we used to only do levels of different hormones in mom's blood. And now we have this non invasive prenatal testing where they take a blood sample from mom while she's pregnant. They look for cells that actually belong to the baby, and then they test the genes that are on those cells. Are those fairly accurate? Is that also still kind of a gray area where we say, like, it looks like something's there, but maybe the gene isn't going to get turned on?
Yeah. Prenatal testing has come a long way. Some of the biggest advancements have occurred in the prenatal space in terms of testing that's available. A lot of it arose out of the desire to try and determine during or even before a pregnancy whether there could be risk to a fetus of having a genetic condition or a birth defect. And so the kind of original screen that we did was just based on something simple like maternal age, just knowing that the incidence of certain chromosomal abnormalities increases to some degree with maternal age. That was used as a basis for doing further testing in those parents, but that screening was not very sensitive. It didn't detect many cases of fetuses that would be affected by chromosomal anomalies or birth defects, certainly. When it was discovered that you could look at the levels of certain analytes, proteins within maternal blood during a pregnancy, and that could give you an adjusted risk of how likely that fetus might have a condition like, let's say, Down syndrome or another chromosomal trisomy, or even certain birth defects with the case of maternal serum AFP levels for open neural tube defects. They started to incorporate that into sort of routine prenatal care. And the gold standard for a long time was the second trimester triple screen, right? And then as more analytes were discovered, that was added onto. They had a quad screen, and then they were able to do it earlier, looking at some analytes that may go up or down earlier in pregnancy, like pregnancy-associated plasma protein A and nuchal thickness on ultrasound. But for all of those tests, they were not diagnostic; they were screening tests. So there was a percent of people who might have a suggestive pattern of increased risk, but yet might not have a fetus that's affected by one of those conditions. And the way to determine that, sometimes it could be fleshed out by doing, let's say, imaging studies in the case of certain birth defects. But in the case of things like trisomy 21 or other chromosomal syndromes, quite often you have to do an invasive procedure like an amniocentesis or a CVS to actually determine whether that increased risk was real or not.
So amniocentesis is where they put a big needle into the abdomen and suck out some of the amniotic fluid, or chorionic villus sampling, CVS, where they would take some of the placental cells and then test those. And those, because you're putting a big needle in the abdomen, they had a risk of causing a miscarriage. And so that's why those were, not standard of care, but can give you an accurate test of like getting the fetal cells out, right?
Mm-hmm. Yeah, you could actually test the cells from the fetus. So it was much more accurate, much more diagnostic, but came with risk. And so because of that, there was a great desire to find better, more sensitive, more specific tests. And there was a discovery that during pregnancy, some of the DNA from the cells of the fetus, primarily from the placenta, will enter into the maternal circulation, and usually in the form of what we call cell-free fetal DNA. So it's actually the raw DNA that came out of cells that, let's
Oh,
say, had lysed. And about
it goes
during
into the mom's blood
it does. It crosses
directly.
the placenta and ends up in mom's circulation.
Wow.
So, as opposed to going and invasively taking cells from the baby, you can actually interrogate the DNA from the fetus in the mom's blood during the pregnancy. It's not something. So, as the pregnancy goes on, the levels do go up. So, once you get to around um, 10 weeks, you have pretty good fetal fraction of DNA in the maternal circulation. And you can look for things like aneuploidies, like trisomy 21, or which causes Down syndrome. You can even look for what we call monogenic disorders. So see if someone has a mutation in a specific sequence of DNA. That's usually only done if there's a reason to think that the fetus is at risk for having one of those conditions, like, let's say, a family history of muscular dystrophy or Fragile X syndrome. But for all pregnancies now, it's recommended that we offer what we call non-invasive prenatal testing, which looks at the cell-free fetal DNA for adjusting the risk of there being an aneuploidy like trisomy 21 or Down syndrome and some other conditions as well. It's a much more, it's not invasive. It's just done on a blood sample. It's much more sensitive than the prior methods. So some of the things like the triple screen or the quad screen or first trimester screening would detect like 70 to 85% of cases of fetuses that might be affected with one of these conditions. But with the non-invasive prenatal testing, you're getting upwards of 99% sensitivity detection rates, with much fewer false positives, so much less need for invasive procedures in individuals who don't have a fetus that's affected by this.
That's amazing. And also, it sounds like you can do it in the first trimester rather than having to wait all the
Yes.
way till the second trimester. So it's a lot earlier on that you would know these things.
Mhm.
That's so cool. Can those tests still be done on people that have twins or triplets?
So they can be done on twins. For many of the conditions, things are pretty well validated. It is almost as sensitive and specific. There may be a
Wow.
slight drop off with increasing numbers of gestations. Then that can be affected, start to be affected a little bit. But there are studies that show that it's still accurate in twins.
So suppose something comes up positive on this prenatal testing for a parent, some genetic condition. Is that definitely there? Do they need a screening test later to see if it's actually that?
So, again, even this non-invasive cell-free fetal DNA is a screen only. It's there are reasons why there could be false negatives or false positives, albeit rare, but certainly we often want to do other things to sort of confirm or validate that the result that we're seeing is real. Um, and so, for example, if the test comes back that there's an increased risk for something like trisomy 21, which causes Down syndrome, usually there will be other markers that you can look for on, let's say, an ultrasound evaluation. And so, if you want to do some non-invasive testing, you could look for those markers and see whether they're present or not. If they're present, then that makes you more confident in the result. If they're not present, it still could be that, but it makes it a little less likely. Ultimately, the only way to know for sure is still to do, an invasive test like an amnio or a CVS.
So those might still be suggested
They might still
after
be
the
suggested,
NIPT.
but if there's enough other evidence from non-invasive testing like ultrasounds, then many individuals would not choose to go forward with that
Yeah.
test. I will say that there can be reasons for false positives. For example, sometimes a parent may actually have a low level of what we call mosaicism, where a couple of their cells may actually have the aneuploidy, and that may be making it look like there's an increased number of copies of that chromosome. Also, there can be reasons for what we call false negatives. So there can be people who have the screen and yet still have a fetus that might be affected by this. And that could sometimes be because the genetic change may be confined to the fetus and less present within the placenta. And so most of the cell-free fetal DNA is coming from the placenta. And so the fetus may have a slightly different genotype. And so if you still see those ultrasound anomalies, you still may want to go forward with an invasive test, even though the non-invasive prenatal testing was not suggesting increased risk. And conversely, if the non-invasive prenatal test is positive, you still may want to go forward with other testing because there can be reasons for false positives there as well.
What are some common genetic things that are present, like in newborns, and that we might notice in the newborn nursery?
Yeah, so I think one of the main reasons why we're all often called to consult are the presence of a birth defect, a congenital anomaly. Many times those are known about during the pregnancy because they're seen on an ultrasound or suggested by one of those non-invasive screening tests. But those are not perfect methodologies, and so sometimes babies are born and they may have a birth defect. About 3 to 5% actually of all pregnancies have some sort of congenital anomaly. Sounds like a lot, sounds scary, but the converse is that 95 to 97% of the time there's not a congenital anomaly, right?
Yeah. And some of those anomalies that you see at birth aren't necessarily significant, right? Like they're not going to need further workup or surgery or things like that. It's just something that happens to be there, right? Or is that
Right,
right?
right. Yeah, no,
Yeah.
that is true. There's not necessarily always a functional consequence or a pathologic consequence to every congenital anomaly that might be present, right?
Okay.
For example, there's an anomaly that we call syndactyly, where there's a small bit of connective tissue bridging between the digits. Sometimes it's minor; it doesn't really affect anything, but there might be, web toes as they call them, but there's no functional significance. But whenever you see that, whenever you see an anomaly, even if it has no pathologic significance. It just means your radar has to go up, that you take a good look and make sure that there's nothing else going on, that there are not other anomalies that are present that had been missed. And also, you have to look for those other cardinal signs of genetic conditions. And some of the signs that we often see are abnormalities in growth. So, was this a baby that had unexplained intrauterine growth restriction or was unusually large without an explanation? Are there abnormalities of neurologic tone? Is this baby abnormally hypotonic or low tone or hypertonic or increased tone? And then, are there what we call dysmorphic features? So mild variations in the physical findings that could suggest the possibility of a genetic syndrome. If you're seeing those things together with a birth defect, it increases the chance significantly that there could be an underlying genetic condition that might have other implications later on, and where genetic workup is going to be important.
When you mentioned tone, what that means is the strength of the baby, how strong their muscles are. So if the baby is more like floppy than normal, that would be low tone, or if they're more stiff, that would be a higher increased tone in babies. So yeah, there are some subtle things that we look for in the hospital to see, like, is there something else going on? And like you said, sometimes they can be missed, but when I notice like 3 or more things in the same baby is usually when I will put in a consult for genetics. Is that
I mean, I would certainly say that if you're seeing multiple issues, then it's never wrong to have a genetic consultation just to look into a little bit further. Some things are really common. So dysmorphic features are very common. In fact, it's normal to have a couple physical features that are slightly outside the normal range. So that alone, just having one or two, slightly abnormal facial features or physical features doesn't necessarily necessitate a genetic consultation. But when you see those in combination with the other things, then it becomes important. Even certain birth defects on their own are known to have a high incidence of underlying genetic causes. And so, even like if you have a congenital heart defect, let's say,
yeah.
there's some common ones. Let's say a
Mm-hmm.
bicuspid aortic valve, which is congenital, but doesn't tend to cause issues till later in life. If you find that, that usually is not going to prompt a genetic evaluation because it's a pretty common finding, and it's pretty unusual that we would find an underlying genetic cause for it or syndrome associated with it. But if it's
Mm-hmm.
a more complex congenital heart defect, like a tetralogy of Fallot or let's say a large septal defect, we do know that there's an increased incidence of underlying genetic changes that can cause that, where there can be other implications. And so it's important to look for those reasons to help provide, proactive care to the child, and also to figure out whether there are recurrence risks for that child when they get older and have kids, or for the family in future pregnancies.
Yeah. And I remember that heart defects are one of the more common things that malformations that happen in babies. And so we screen for those both by listening to baby's heart in the nursery, but also by doing what we call the CCHD, or critical congenital heart disease screening, which is where we put a pulse oximeter, which is a light just on baby's hand and foot, and see if there's a difference in the amount of oxygen that's going from one to the other. Would you say most things are caught with those 2 screens while the baby's still in the hospital, or do these sometimes show up later in life?
Yeah, I would say that a large percent certainly are caught, and especially the ones that are likely to have early functional significance
Yeah, the
through
more
those
dangerous ones.
methodologies.
Yeah,
Exactly.
yeah.
There are many more so congenital heart defects actually occur in almost 1% of
Wow.
all live births. It's 0.8% technically. So it is probably actually the most common type of birth defect that we consider. Some of them have significant functional consequences. Most of those are picked up with the newborn screening that you mentioned, or through physical exam. But there can be, again, more mild anomalies where there may not be a distinctive audible murmur that you might hear, and there may not be a problem with the pulse ox, and therefore it might go undiagnosed. So but it certainly is detecting a lot of the critically important ones.
So for some children who are later in life to need genetic testing, I know that sometimes when children have autism, we do genetic testing to look to see if there's anything else going on. Is that universal in all children who are on the autism spectrum, or are there certain other things that, say, a general pediatrician might look for before making this referral to genetics? Or are there other reasons that, I guess, older children would get referred to a geneticist? Something that wouldn't be present in the newborn period.
Yeah, I would say that there's an increasing awareness that many conditions that have been, until relatively recently, unexplained in some cases, or even in a majority of cases, have a genetic origin, and that we are using new genetic technologies much more often able to detect, which can be important, again, in providing the necessary medical care to optimize their development later in life. Developmental disabilities, including autism amongst them, are a group of conditions where quite often there is a specific genetic reason that can be uncovered, increasingly so with newer genetic testing. And so things like what we call whole exome sequencing or whole genome sequencing, where we're not looking just at the DNA sequence of a specific gene for a specific syndrome, but rather looking at thousands of genes all at once, are able to uncover a cause for things like autism in upwards of about 50 to 60% of cases now. In the remainder of cases, there may still be genetic reasons that just were not able to be identified using those methodologies, and there may be some other tests that we can do to increase that fraction a bit. And that is really an essential thing, because it just, can relieve some parental burden of anxiety that they may have done something, let's say, during or before the pregnancy that caused
Yeah.
the child to have those aberrant behavioral developmental patterns. But it also can be important in terms of finding potentially treatable conditions that sometimes arise through genetic testing, and also in better informing families about the chance of recurrence in future pregnancies as well. So lots of reasons to do it. But a condition like autism is something that, yeah, you're not going to see any obvious symptoms right at birth. And so it's going to be later when those aberrant behavioral features become more noticeable. And so the current recommendations are that anyone with unexplained, regardless of age, whether they're child, adolescent, or adult, with unexplained intellectual disability, developmental disability, autism spectrum disorders, should have certain genetic tests. And first line amongst them is actually the whole exome sequencing.
Just going back to the newborn stuff, I forgot to ask about the newborn screen, which I know you mentioned treatable genetic diseases. And so we do this newborn screen in babies before they leave the hospital. And we're looking for a bunch of things because they can be treated. And if they are treated, they can have lifelong consequences. And if they're not treated too, it's lifelong consequences. Can you just lightly touch on that for parents? Like what the newborn screen looks like, how it's done, and what sort of information we gain from that.
Absolutely. So yeah, newborn screening is an invaluable tool for, as you mentioned, detecting a number of different conditions, mostly genetic, but even some non-genetic conditions, where if we waited for symptoms to occur to allow us to make the diagnosis, and then started treating after that point, we would end up with significantly worse outcomes. And so by screening before symptoms occur, by screening right at birth, we can detect those conditions earlier, and we can ideally start treatments before those symptoms have irreversible consequences. And that's been shown to be the case for a number of different genetic conditions. And in fact, that list is ever expanding, because as we develop new therapies for previously untreatable conditions, and when we discover that initiating those therapies earlier or before you would have made a diagnosis after waiting for symptoms to occur, you can get better outcomes. The need for expanding those panels even more becomes of critical importance.
Yeah, that's awesome. And I know some of the treatments for those are as simple as they need to be on a special formula instead of breast milk or things like that. I imagine some get more complicated than that.
Absolutely, absolutely. And even for some of those, we have other treatments that are a little more complicated, but often more effective. But the kind of prototypical case in point is something like phenylketonuria, or PKU, right?
Yeah.
Which is a disorder, an inborn genetic disorder of metabolism of a particular amino acid called phenylalanine. And when you can't metabolize it, it builds up and causes toxicity to the brain, and also deficiencies of some downstream amino acids. And so before we had newborn screening, these patients were only identified because they developed unexplained, pretty severe intellectual disability, a high incidence of autism, and some other characteristic physical findings. At that point, many of those were irreversible consequences. It was discovered that if you treated patients with PKU with a diet that was restricted in phenylalanine, using, as you mentioned, metabolic formulas that have the other essential amino acids, but much reduced levels of phenylalanine, that you could control those phenylalanine levels. And the earlier you started, the better the outcomes, right? And so that was the big impetus for having that added into newborn screening so that we could identify these babies before that irreversible damage, institute that relatively simple initial, restriction of phenylalanine in the diet, and end up with near normal outcomes.
That's so cool. And you had mentioned, just coming full circle now back to the beginning of the podcast, you mentioned that sometimes we even do testing before parents are pregnant. And what does that look for? What is that doing? How does that look like? What sort of tests are those?
Yeah, so there are a number of reasons why we might offer genetic testing to prospective parents even before pregnancy. Most obvious probably is that there's, let's say, a known family history of a genetic condition. And if it looks like one where there could be risk of transmission, families may be offered testing to see if they are a carrier for one of those conditions. But even if there is no family history, many genetic conditions occur in what we call a recessive pattern, where both parents may be carriers, need to be carriers, but they are usually unaffected, so they might not know that it's in the family. There are increasingly robust screening panels for autosomal recessive mutations that people could be carriers for. We all carry, everyone carries a half dozen or so of these genetic changes in genes that are not affecting us. But if our partner carries a change in the same gene, we have a risk of both passing it on to our offspring, about 25% risk with each pregnancy. And those are conditions that we're able to screen for before conception, so that if two parents know that they're at risk of having an affected child, they can avail themselves of all the different options to reduce the chance that the child might have that condition. Sometimes that involves deciding on using a donor egg or a donor sperm that's shown not to be a carrier. Other times that's using something called pre-implantation genetic diagnosis, where eggs and sperm are harvested from the prospective parents who we know are carriers, to make sure that you then test the embryos before implantation to make sure that the ones that you would implant would not be affected by the condition.
That's cool. So it's like IVF and testing the little embryos before you put them back
Exactly.
in. Wow.
IVF with pre-implantation genetic testing.
Is this something that everyone should do before having a baby? Or is this like what sort of parents should think about doing prenatal genetic testing
So we
on
recommend
themselves?
and we offer prenatal carrier screening. And preconception carrier screening even before pregnancy that's the ideal time to do it, because if you do it before pregnancy, you can use things like IVF and pre-implantation genetic testing, as opposed to having to only face the decision of testing during the pregnancy and then whether to continue the pregnancy, knowing that information. And so ideally, you want to do this carrier screening preconceptually before you get pregnant. The current recommendations are that all individuals, regardless of ethnic background, there are certain genetic conditions that you see a little more often in certain ethnic backgrounds because of what we call founder mutations or other reasons. But all individuals, regardless of ethnic background, should be offered preconception carrier screening. And those panels have, as I mentioned, become much more robust. And in the past, there was only like 2 core disorders or 4 core disorders. Now these panels are able to screen for carrier status for hundreds of different conditions.
Wow. That's really cool. So it seems like the overarching message with genetics is the sooner you know, the better, right? The better the outcomes
Right.
for
It definitely
everyone.
gives you the opportunity to intervene and achieve better outcomes, or even in some cases prevent passing on genetic traits that might cause these conditions.
Are there any common genetic conditions you can think of that would have the need for other specialists to be involved? Like things that
Absolutely.
tend to have all these other, but yeah, can sort of touch on a couple of those. I know with trisomy 21, we always want to involve a cardiologist because they have a higher incidence than the normal population of heart defects.
Genetic conditions, some of them may present only affecting a single organ system and may not necessarily need what we call multidisciplinary care. But
Hmm.
many genetic conditions, especially syndromes, are groups of things running together affecting multiple organ systems, and those patients benefit from multidisciplinary care. In the case of something like trisomy 21, where there can be effects on the neurologic system in terms of tone and cognitive development, where there can be effects on the heart in terms of congenital heart defects, on the gastrointestinal tract in terms of various kinds of mobility issues or congenital anomalies, on the endocrine system in terms of hypothyroidism. You can see that we have to have a whole cadre of specialists that are involved in helping manage these patients to get best outcomes.
Awesome. So I imagine that's something that, say, I guess, latest case scenario would be picked up maybe in the newborn nursery or on this prenatal testing. And then the doctor that's their general pediatrician or their obstetrician might even start making suggestions and recommendations for what type of specialists they might need to see.
Absolutely. So, many times and increasingly so, we're identifying it prenatally, something like trisomy 21. And then families will be counseled about the full spectrum of potential medical issues that could arise. Also, what kinds of care teams they will be connected to help optimize outcomes. And if if the condition is not found prenatally, then many times at birth, the telltale signs of that condition will lead to a consultation with a geneticist to help confirm the diagnosis, or perhaps the neonatologist or pediatrician may send the genetic testing, the chromosome analysis, and make the diagnosis. And at that point, then you would be looking for all the different things that can come along. They don't always come along, but can come along with that diagnosis, and making sure that the right specialists are brought into play.
I don't know if we could just provide a little reassurance. I know I've had a lot of friends reach out to me because something was found on ultrasound that ended up not being significant in the end. Things like, I mean, like a two-vessel cord, is that something that they need to worry about? Or a spot, a bright spot that shows up on the heart or a bright spot on the back of the neck. Can you just say, like, are those likely? If they just find one thing, I feel like a lot of the times that doesn't mean a whole lot.
Yeah. So there are a lot of we call soft markers on ultrasound, which are subtle changes that may or may not by themselves cause any issues for the baby. But when you see them prenatally, they are risk factors for potentially having certain genetic conditions. And the more that you see, the more likely that one of those conditions might be present. And so you don't want to cause undue concern because there's a good chance if they find a particular thing that the baby may not be affected by one of those conditions. But you do want to take a closer look and make sure that there aren't other ultrasound markers that you're finding, or you may want to go forward with other genetic testing to look into it further if people want a higher degree of certainty about that. There have been tremendous advances in our understanding of the genetic basis for a number of conditions that were previously unexplained. And so genetic testing and evaluation is becoming much more commonplace and much more important for a host of different conditions, both pediatric conditions as well as adult onset conditions. And some case in points are things like epilepsy, right? So we now know that with unexplained epilepsy, we can find a genetic etiology, again, in upwards of 50 to 60% of cases. And many times it's using that newer technology of whole exome or whole genome sequencing, which gives us, it looks like, the higher yields and is making its way into the first line for evaluation of those conditions. And the reasons, again, are not just to provide a label, but if you find the etiology, there may be specific treatments that will work better for those patients and give you better outcomes. And it's the same thing for epilepsy as it is for autism, and even in some cases for adult onset conditions like, let's say, Parkinson's disease. If there's a family history or an unusually early onset, genetic testing is starting to become increasingly recommended to try and parse out the reasons and see whether there might be therapies or clinical trials that would be able to help patients with those specific genetic causes.
That's really amazing. I feel like genetics is probably the one field that has come the farthest in recent years. That there's just been so many like updates. Back when I was in medical school, which was, I don't know, like 20-ish years ago at this point, a lot of the treatments for this were what they called genetic counseling, which was just like, maybe don't have any more kids right now, and until we figure out what's causing this. And now it's like there's actually individualized therapies. There's things that target specific genes, whole genome sequencing. I remember in high school learning about how they were mapping the human genome, and then it was done. And now we just know so much more than we did not even that long ago. So it's pretty incredible how far this has come, and like how much more optimistic I am about the field of genetics versus back in the day when we were like you said, it was like playing house. But then once you found the diagnosis, you were like, we can't do anything about it. So, yeah.
Absolutely. Yeah, it's a truly exciting time to be in the genetics field. And one of the most encouraging things is that we're moving from the phase of just being able to figure out, okay, this is the genetic cause of the condition, to actually saying, how do we translate that into guided precision treatments that correctly underlying genetic etiology. And so whether it's through RNA-based therapeutics or gene therapies or just targeted small molecules, for an ever-increasing number of conditions, we're able to offer treatments, not just counseling and reassurance, but actual interventions that can improve care.
That is so awesome. Well, thank you so much for being here today. It was a real absolute pleasure to talk to you. You're one of the smartest people I've ever met, and this was really enlightening. I hope our listeners have also found it really interesting. Thank you for tuning in. Make sure that you like and subscribe so that you can be the first to know when new episodes come out. Also, you can check out the first 4 seasons of the Baby Manual podcast on your favorite podcasting platform, or check out my YouTube channel for lots of videos and shorts that will help you feel empowered as a new parent as I answer all of the common questions that tend to come up in the first couple of years of life. Have a wonderful day.